chemotherapy tend to start with puncture and ablate at the tumor center. Ablation at the center of the tumor causes an increase in intratumor pressures. The tumor microthromby then allows the vessels attached to the tumor and extrude the portal vein and go to the peripheral liver parenchyma. This is my experience of rush recurrence after RFA. These patients had like this HCC, and RFA was done. Necrotic area obtained like this, and after 6 months is RFA, we looked the multiple recurrences in the peripheral parenchyma. So we think about it is very important is tumor pressure. So how to do MCM? At first, we try to insert a needle near the feeding artery or drainage vessels, and heated blood extended the vessels surrounding the tumor will make microthrombi inactivate like this. So we made the first exercise edge and not in the center and perform many times in the insertion and coagulation. This procedure could probably make it possible to avoid any unwanted elevation in the intratumor pressure, which we believe is the most important way to prevent tumor dissemination. And MCM has a less heat sink effect. The cooling effect of blood flow is greater within the zone of RFA than MCM. Microwave ablation is less affected by the perfusion-mediated heat sink effect and may allow uniform tumor killing next to blood vessels like this. But please care about when you treat nearby the bile duct. Bile duct is very weakness by the invasive of thermal ablations and elevation of the thermal. So we do many times, and insertion is required. So MCM is always carried out under laparotomy or short thoracotomy or laparoscopy. When we treated the HCC in the dome, small incision like this and thoracotomy and via diaphragm and MCM was done. In the era of invasiveness, this more invasiveness is very but the results is very good, I think. In your proceeding books, results of my abstract is missed, so please look at these results following slides. A total of 2,612 patients with SCC underwent hepatic surgery at our facility between July 1994 and December 2012. Of 834 consecutive naive cases of SCC who treated by MCM, we analyzed overall survival or others. This shows the characteristics of all patients with MCM. Mean tumor size was 26.4 millimeter, and mean tumor number is 2.5. Cumulative survival of all patients, 5-year survival rate was 61.8%. If you analyze cumulative survival stratified according to child-pugh class, of course the child-pugh class B was worse, but 5-year survival rate is 44.4%. And cumulative survival stratified according to Milan criteria. Within the Milan criteria, you have a good results. 5-year survival rate is 69.1%. It is same as liver transplantation, I think. And cumulative survival of patients with single SCC less than 2 centimeters in diameter treated with MCN is almost perfect, and 5-year survival rate is 95%. And with multiple lesions, we do treat it with an open laparotomy. So with formal of multiple tumors, 5-year survival rate is 48.7%. We think this is better than the results achieved by TACE or hepatic arterial infusion. And cumulative survival of patients with 3 theory inside with hepatic resection, MCM, 5-year survival rate was 70.4% for the MCM group. No significant differences between found in cumulative survival rates with MCM versus hepatic resection. And also the local recurrence rate at 1 year in the MCM group was 2.4%. Again, there was no significant differences in the local recurrence rate in the two groups. So our research shows that MCN is effective for local regional control of MCN comparable to hepatic resection. MCN should be considered as one of the first choice treatments for SCC, even for patients with poor liver function like a Child-Pugh class B or multiple lesions. Thank you very much for your attention.